We know you have lots of other obligations, so we're thankful for your time. Dr. McGuire's medical director of liver transplant, and since I've been at UAB, has been a favorite from GI hepatology resident education. So we're always excited to have you on service, and we're thankful you're here to give some education to the hospitalist service. So with that, I'll let you take it away. We're excited you're here.
Well, thank you very much, Ashley. I appreciate that. So I have actually 3 different cases wrapped up into one, and it's all a true story. But hopefully it'll go through the points and make you understand essentially hepatitis B and C. Okay, so that's the hope. So okay, so I should be sharing the screen if that's correct.
Yeah.
Okay, and I will. Okay, and we should see the screen there, and so I will start. Okay, so this essentially is the case. We all get it. Lou Bridges, who was here, who is eventually up in New York now. He had a clinic one day. I had a clinic the same day. He calls me up. He says, "Hey, I have a patient here, and her daughter is yellow. Can you see her today?" And I said, "Great." So I agreed to see her. And so that's what started this story, and we'll go from there. So essentially, she's a 55-year-old female with an acute liver injury. When you ask her, she said 6 days. She's had of fatigue, abdominal pain, nausea, vomiting, diarrhea, 3 days of yellow eyes and skin and tea-colored urine, tan stools, denies any known contacts with anyone with hepatitis, no travel history or eating deer meat, wild boar, wild mushrooms, past medical history is positive for fibromyalgia, medications, ginkgo, glucosamine, and turmeric, curcumin. She lives with her husband and her mother, who moved in 4 months ago after surgery for diverticulitis. She says she drinks a bottle of wine on weekends. So when you get a question like this, and any of you questions or any comments you get throughout, just either yell at me or pull it out in the chat box. That would be fine. So essentially, you know, and you get board questions with this too. You know, when you say you're denying travel history, you're essentially trying to push away like hepatitis E or hepatitis A when you're essentially talking about deer meat or wild boar. You're essentially trying to exclude hepatitis E because that's the #1 cause here in the United States, is exposure to raw deer meat or raw wild boar. Wild mushrooms, we all know that's Amanita. You know, that tends to be more associated with out west. Phil Rosenstein, who's actually at UCSF, his career was built on a lot of cases he had many years ago. I've only seen one time where a family had Amanita toxicity. That was in Minnesota. Dad went out, picked mushrooms, put in the omelet. Everyone ate it for breakfast. Later that day, really around late evening, they all showed up with nausea, vomiting. And the daughter didn't like it, so she actually gave hers to Dad. So Dad ate the most. He was the only one that was really hospitalized. And we talked about transplant, but his liver fortunately got better. So when you think of other things too, you see, you know, ginkgo, glucosamine, turmeric. Turmeric has been associated with acute liver injury, but still pretty rare. But alternative medications need to be considered. And then you see your history of alcohol use. Is it truly just a bottle of wine on weekends? Is it more? You never really know. So I think that's something you need to take in consideration. So physical exam here is pretty unremarkable. She's jaundiced, she's ecteric. Otherwise, there's no asterixis, so she's not really encephalopathic. You look at her labs, hemoglobin, white count, platelets are all normal. The rest of her BMP essentially normal. Albumin's normal. You know, so a normal albumin, since albumin has a half-life of 21 days, that's essentially excludes really any chronic exposure. So it's not like she has liver failure that's been going on for a long period of time, and she has cirrhosis, for what that's worth. So her albumin's normal. Now we get to the liver labs. Her bilirubin is 28, direct is 19, alk phos is 198, GGT is 300, AST, ALT, essentially 1200, iron, iron SAD essentially normal, but the ferritin you see is 5,000. Creatinine 72, INR is 1.15. So now you got someone that's very concerning as to, how serious your acute liver injury is. And the question always is, do you admit someone who has transaminases over 1,000? You need to admit everyone that way. What can you do with them? I'm kind of a fan that I like the INR. Really an INR, once it gets close to 2 or over 2, I think you're kind of committed that you need to admit them. INR of 1.15, you probably aren't obligated to admit them, but you do need to follow it closely. You definitely would need to get labs within a week just to see where the INR is trending. You need to figure out what the cause is too. That would be helpful too. If we find out this is from acute hepatitis A, most of them resolved, probably doesn't have to be admitted. So I think the cause will determine too where you go with it too. So ferritin, what do we think of ferritins over 5,000? It's concerning, but you see this very commonly. It's an acute phase reactant, as we all are aware. When transaminases are elevated, it's usually associated with cell death. The AST, ALT are released from hepatocytes. The same thing would be said with the ferritin. So with the ferritin that high, I tend not to jump up and down and start thinking down other pathways, usually more associated with an acute liver injury. But again, it's not hemochromatosis. Hemochromatosis will never present with an acute liver injury. It tends to be a chronic disease for many, many, many decades. So that's how I interpret the labs. That's how I see them. And we'll look further. So she had a Doppler ultrasound like she should get. Liver was 19 centimeters enlarged, nodular surface. They said compatible with cirrhosis. You'll see this sometimes, and I see this all the time in the patients with acute liver injury. And a lot of times they will get such an acute event that their liver will collapse. And then as it regenerates, it'll have a nodular appearance. So you shouldn't use that only as your only criteria for really cirrhosis. You need to look for other markers. Other markers would be splenomegaly, ascites, or anything else that would push you in that direction. And as you see here, there really is no ascites. Spleen is normal size, no Bill-Dill, no ascites. IVC is normal size too. If the portal vein was dilated too, that would also push you more towards portal hypertension, but it's not seen here. So, when I get an ultrasound like this, even though it's classified as cirrhotic, it always makes me shake my head and wonder whether it's true or untrue. So that's why I think you have to look at an ultrasound in relation to the patient and how they are. So right now I would actually lean, it's not cirrhosis, but we'll get to it further. So you get additional labs. As you see here, you got an ANA, anti-smooth muscle antibody, IgG, they're all normal. These are our 3 autoimmune markers, right? They're not great markers though. Anyone who you're really leaning that this could be autoimmune, I almost am convinced that you really need to biopsy them, because treatment, as we know, is pretty tough. It's steroids. Steroids have a lot of side effects. It's azathioprine and other medications that'll suppress the immune system. So I think if you're leaning, think this autoimmune, even if you have negative markers, sometimes I will still get a liver biopsy to push it further. It's a female. Unfortunately, you got to think autoimmune diseases in females too. So it's high on the list, but with normal IgG, anti-smooth muscle, ANA, it's lower on my differential. Should we really look for Wilson's disease? You see a ceruloplasmin here, it's 32. Someone 55 years old, pretty rare. You need to think probably something else along with it. If it's an acute liver injury, they probably should have a low alkaline phosphatase, because people who have Wilson's disease, they'll have copper overload. The copper tends to replace the zinc that's needed to make the alkaline phosphatase. So that's why you tend to have low alkaline phosphatase levels. And it tends to be associated with, and you don't see transaminases really over 1,000. I mean, usually they're sitting maybe 1 to 300, somewhere in that range. So Wilson's disease, even though it's in the differential, I think it's pretty low on someone who's 55, and there's nothing else really suggesting it. So let's look at hepatitis viral markers. So you see here, hepatitis A is negative, hepatitis C is negative. Here we have B surface antigen that's reactive, surface antibodies non-reactive, hepatitis B e antigen is reactive, hepatitis B antibody is not reactive, hepatitis B core IgM is reactive. And then you get a DNA level that's 800,000. So when I see something like this, what am I thinking? What are my thoughts? As we know, hepatitis B is a saturating system. So you either have antigen or antibody, you don't have both. In this particular case, that actually holds. So the surface antigen, the e antigen. So I'll go through the next couple of slides, just try to give a better feel for hepatitis B and what markers to think about. And I think if you understand the process and how this all happens, I think that makes a lot more sense. So with hepatitis B, as we're told in medical school, and I told some of you in medical school, that hepatitis B really makes 3 proteins, envelope, core, and surface. Really idle idea, okay? Really surface, actually, there's 3 different types. There's a short, medium, and a large. Really creative, huh? But essentially, it's the same, off the same DNA, but there are 3 different sizes. Does that really make a difference? Probably not, but Israel, they just approved a new vaccine. Our vaccine actually includes one of the proteins of the surface. With the Israelis, they just approved a new hepatitis B vaccine that actually includes all 3 of these, the small, medium, and the large. And they think it's better than what we currently have. And I think trials will start in the United States and see whether that's a better vaccine that we should be using. So just FYI, so you may hear about that in the future. With surface, then you see its location here. You see core being inside here also, and then the E, which you have. My comment is, and other things to think about, is whenever the virus replicates, always going to make surface, always going to make core, but envelope is actually not needed for the virus to replicate and to move on. That's important in some of these chronic cases that we'll talk about. So this is actually the DNA structure as we're familiar with. It's a circular DNA. I mentioned E, core, and the 3 different surface. There's also a hepatitis B X protein that they're actually not sure exactly what its role is or what it does. I think that's to be determined. But be familiar with the other ones, and we'll go from there. But this circular DNA, as we're familiar with, is actually located inside the nucleus. And right now we don't have any good treatments, but we hope down the road we'll have good treatments for it. And this kind of shows the life cycle actually of hepatitis B. And as you see here, it enters here, it is involved in that the circular closed loop DNA is here. It'll make the various RNAs. From the RNAs, then they'll make the various proteins. And these are the proteins you see here. And then it actually will reassemble such that it'll leave the hepatocyte. What's interesting about this, and the reason I put this up, sorry about that, is that they're working on entry inhibitors. They think they can block the entry site here and then block the virus from getting inside hepatocytes. And they can, it may have some interesting long-term things. They think they may be able to clear it. The other thing they're working hard on is trying to do the silencing for the circular closed loop DNA. They think if they can break that open, they think they can cure it too. And I'll bet you really in the next couple of years, that probably has the most promise that if they can get that, that will be successful. As we're all familiar with, there are other things out there. There's immune modulators that, such as interferon, that actually will affect your immune system. We rarely use that anymore. And then we're associated with our protease inhibitors that essentially work right here in terms of the reverse transcription step. And that's been very successful. They're also looking to see whether you can block right here or even have core inhibitors that actually bind to the core. They think, can you also silence some of these RNAs such that they don't replicate and make all these proteins? We are involved in a study for alpha-1 antitrypsin where we have a silencing RNA that actually shuts down alpha-1 antitrypsin. Also, we have patients with acute intermittent porphyria, and I've used numerous times a medication called givosiran that actually will shut down ALAS1. It's a silencing RNA. So I think the silencing RNA can be pretty effective, but unfortunately, I think that's a chronic thing. So I think successfully to clear the virus, I think we have to really go after it in terms of the closed loop DNA. So this is just my last slide on B before we move on to the case. But essentially, if you look at it this way, I think this kind of helps. Since the virus replicates, we say it'll always make surface, always make core. It doesn't have to make E, and the virus will mutate when people have chronic disease and they actually won't make E. But if you're going to make surface based on its size and polarity actually can transfer across the membrane into the cytoplasm. That's why we can measure hepatitis B surface antigen in the blood. Same thing with E. If it's being made and replicated, then it'll transfer across the membrane into the blood system. Core is a little bit different, and that core, based on its size and polarity, cannot actually transfer across the membrane. So that's why we never measure core antigen in the blood ever. It's only in the blood really for short periods of time. If someone has an acute infection or there's a lot of cell death, and then core can release that way with the cell death, and you can actually measure that. But generally we don't. That's why instead we measure core antibody, and we'll talk about that later on. So, but knowing the polarity and the size and which ones can go across makes a difference, makes you understand, I think, the markers that we check and why we check them. So here are the markers that we check, and this is why we check them. So people who get exposed for hepatitis B, usually about 3 to 4 months, 2 to 4 months, really either way, is probably when they were exposed to it to when they started having symptoms. And as you see here, people are either antigen positive or negative, and there's really no overlap. We're all familiar with hepatitis B surface antigen, how it comes up and comes down. E actually does the same thing. I put this gap here. It's kind of longer than what it really is. It's probably really narrowed, and we have such good testing now with hepatitis B. We always heard about this window that existed between surface antigen clearance and hepatitis B surface antibody production. I've only seen one case since I've been here, and that was in the late 90s of someone who had acute hepatitis B. So as you're familiar with, when someone comes in with acute hepatitis B, you want to check surface antigen, surface antibody, and then you're also checking hepatitis B core IgM. We're checking core IgM just because of this overlap period. But again, it's so rare. We're part of the acute liver failure study group. We're one of 20 centers in the US. Will Lee is also on it. And when I asked the group one day, have you anybody ever seen this window period be positive? Will Lee was the only other person that did. And he said he saw that in the late 70s. So it's pretty rare. Okay, so I think if this was updated, I'd probably just slide this anti-hepatitis B over some, just really to close it right here. But essentially, our individual, I'm associating, she's probably been exposed about 12 to 16 weeks ago. She's showing up here because her e antigen's positive, surface antigen's positive, and her IgM is positive. So the core IgM, that'll be positive for essentially the first 6 months, and then hepatitis B core antibody is actually positive after that. As our nurse practitioner says, she says, men will hang around for 6 months. So that's why the IgM is only positive for 6 months, but her girlfriends will hang around forever. So that's why her IgG is positive. It's one way to remember it. So now we're moving on to our individual. So I inform her that she has hepatitis B. She insists, once I tell her this on the phone now, that her husband's cheating on her. Okay. He works in maintenance at UAB Hospital. And she says, I need to see him immediately. And I said, fine. So she also had issues with nausea and vomiting. I questioned whether she should be admitted, as I said earlier, but I decided not to. She says she couldn't be admitted even if she wanted to because she was taking care of her mom. So I said, fine. So I agreed to start her on tenofovir 25 milligrams a day. And I guess, why did I choose this agent? I mean, you can use this or entecavir. I think both of those agents are excellent agents. They work very well. This is Vemlidy, which is newer version of tenofovir, associated with less side effects than Variad, which was the older version that was 300 milligrams a day. I guess I did it because there's data, and the data is really with patients that have more severe disease. That if you had a bilirubin greater than 10, an INR greater than 1.5, that there's at least been 3 studies that I know of where they put people on oral agents and they were able to suppress the virus. They were able to minimize the symptoms. They're actually showed that they've decreased mortality. One of those 3 studies, and it was the first one done, said you may have had increased development of developing chronic disease. And that was the concern, but the 2 follow-up studies actually did not show that. So I think there's no reason not to put on an oral agent if you're really concerned about the symptoms and you're trying to keep someone out of the hospital. So that's why I did it. It is very expensive, though. Don't get me wrong. It's probably like $800 a month for the tenofovir, but we know it works and the side effects are pretty minimal. So I elected to treat her, and I agreed to see her husband, as I said. So I see him the next week, and he goes, I'm here alone because my wife doesn't trust me. He says he has no known history of any liver issues whatsoever. Past medical history is really negative. He says he's living with his distrusting wife and his mother-in-law. He says he drinks 2 to 3 beers a day, denies any travel history, no eating deer meat or raw wild boar or any wild mushrooms. He says he does have a history of IV drug use as a teenager, but that was before he got married, nothing since. He's on no medications. So I get his labs. White count is normal. Hemoglobin's normal. Platelets just a hair low, but they are low. Okay. And that's a little red flag, not a big red flag, but it is a little red flag, as we're all familiar with. The liver senses the platelet count. If the platelets are low, the liver will make thrombopoietin. Thrombopoietin will stimulate the bone marrow to make more platelets. So it's low. So that almost tells us that there may be a liver issue going on here. I actually think it's a great sign for indicating whether someone has portal hypertension or not. If I have a cirrhotic and they have a normal platelet count, generally I don't do anything with them. I don't screen them for varices. I will screen them, though, for hepatocellular carcinoma if they have cirrhosis, but if they have a normal platelet count, the risk of having portal hypertension is really very, very low. So you see here, sodium, potassium, chloride, bicarb, BUN, creatinine, glucose, pretty normal. Calcium, total protein, normal. Albumin, if you notice, is just a hair low. Not much, but it's a hair low. And again, albumin with half-life of 21 days, pretty concerning. So he's leaning I think, to some form of liver disease just based on what I have right here. What else do we have? We have total bilirubin, 1, outphos, 100, AST, ALT, 38 and 43. So technically they're normal, but as we're all familiar with from an article over 10 years ago now, in the Annals of Internal Medicine, the AST, ALT, that's the normal range, that was derived in the 60s before we had any markers for Hep B, for Hep C. We didn't really screen people for NASH. So, in retrospect, probably for a male, a normal ALT probably should be 31 or less. In females, we think it's probably 19 or less. So, 43 is just a hair high, and probably not normal. INR really just a hair prolonged. So that's the other thing, start thinking maybe there's something else going on. So I get his labs. Hepatitis B surface antigen negative, hepatitis B surface antibodies reactive. Okay. E markers are negative, core is all negative, DNA is negative. So what does he have? So this individual essentially, hopefully like all of us out here today, this individual was vaccinated, received hepatitis B surface antigen, developed antibodies to it. He's a UAB employee since he works in maintenance. They all get vaccinated. And that's what he was. He was vaccinated for hepatitis B. So still concerning. His labs are just off a little bit, but I essentially I call him the next day. I explain he does not have active hepatitis B. He does have antibodies suggest he was vaccinated. He says, I need to explain this to his wife. So he called his wife over. I said the same thing to her. I did tell him, though, that he probably needed to quit alcohol and I need to follow up on his abnormal LFTs. And he said he at least would cut back at the time, but he wouldn't quit. So additional labs come back. As it's hard to know what a diagnosis is. So you almost, with anyone with liver disease, you just got to throw out the gambit. We do pretty routinely. We do iron studies, which were normal on him. Autoimmune markers, which were normal. IgG is up a little bit. You see that sometimes just with cirrhosis alone, maybe a red flag, maybe not. Ceruloplasm, do you really need a ceruloplasm on a 60-year-old? No, but again, it's our gunshot protocol that we do. We just check everyone. Alpha-1 antitrypsin was normal. TTG looking for celiac disease was essentially negative. Okay. Additional labs now. So these are the metabolic labs that we'll get, and they're pretty unremarkable here. Genetic testing, you probably didn't need it with normal iron studies, but it was gotten anyway, that was negative. AMA for primary biliary cholangitis, that was negative. Phosphatidylethanol is positive, but he admitted he was drinking a couple drinks a day. So not surprising. I like phosphatidylethanol, as you guys are aware, has a half-life of essentially 4 days. For really anyone who is drinking, it may miss people if you're drinking 1, maybe 2 drinks a day, it may be negative. We're all familiar with the oxidative pathway. This essentially is looking at the non-oxidative pathway. And if it's going to be positive, it'll be alcohol and really nothing else. So, you generally, what is really significant? I think anything over 500, I mean, that's a significant amount. And you're probably drinking at least 6 drinks a day. And this probably goes along with his history that he was drinking 2 to 3 drinks a day. So his level is 151, which is positive. Hepatitis A was also checked. It was non-reactive. Hepatitis C was reactive. Okay, probably in his HCV RNA was 3 million. A genotype was 1A. Alpha-fetoprotein you see here is a little bit elevated at 31. But again, we use that as a cancer marker. It's a tough marker to use, especially as a screening test, since alpha-fetoprotein is only elevated half the time in individuals with hepatocellular carcinoma. But I guess we generally get it because if someone has a liver lesion, they have cirrhosis, they have an elevated AFP, it's really HCC, and there's nothing else it can be. But in this case, though, mildly elevated, I'm not sure what to make of it yet. Probably more related to his elevated transaminases. So he also got a Doppler ultrasound, which showed in a large liver of 21 centimeters, heterogeneous echotexture, nodular surface compatible with cirrhosis. Different than the last one from his wife, though, in that his spleen is enlarged, there is trace ascites. So in this case, with a low albumin and these findings, and even the Doppler showing portal vein enlargement with slow flow, I'm favoring that he has cirrhosis, that he has portal hypertension. So how about just a couple slides on Hep C, and then we'll come back to them. So we're all familiar with Hep C. Essentially, take 100 people, 20 will clear it on their own. The other 80 go on to chronic disease. The question is, of those 80 with chronic infection, where are they going to pan out? It depends on other risk factors. If you're drinking alcohol, if you have hemochromatosis, if you have Hep B on top of it, if you have fatty liver disease, you're more likely to go on to cirrhosis. If you really have no other comorbid condition, there's a lot of people that'll have chronic hepatitis and have it for the rest of their lives. The average time from acquiring the virus to going on to cirrhosis is about 21 years. The average time from acquiring the virus to going on to hepatocellular carcinoma is about 28 years. So there's like a 7 years difference. But I do encourage, if you have any patients with cirrhosis, that they really need to be screened for hepatocellular carcinoma, since the risk of hepatocellular carcinoma in someone with hepatitis C induced cirrhosis is like 1 in 25. Even if you clear the virus, the risk is still 1 in 25. It does not go away annually. So they either need an ultrasound every 6 months or a CT scan once a year. What do we know about hepatitis C? It's just been so cool to see a lot of the virologists that started with HIV, and they actually created some of the drugs at the time to treat HIV that actually cleared hepatitis B. Once they worked on HIV, then they all moved on to essentially hepatitis C. And this is where we are with hepatitis C. There are essentially 10 proteins that hepatitis C makes. We thought originally that these protease proteins, or these are the proteins that actually will cleave the various different proteins and give you, it's one strand, and it'll break them up into 10 different proteins. So we thought if you could get a drug that could fit into the Ns3, Ns4a and bind there, that would prevent the virus from replicating and you had the disease cured. The only problem with that is that there was a lot of resistance that occurred when you had drugs that actually fit in here. So if you do develop resistance with just this agent alone, the resistant strains tend to be pretty fit and robust, so that they will maintain and they will hang out for a long period of time. So that didn't work. So the protease inhibitors, though, they're essentially any drug that ends in PREVIR, Previr. And the only reason I put an asterisk on this one is that Mavorite includes one of these drugs. So then the next thing they learned is that the Ns3, Ns4a, the Ns5a, Ns5b, essentially all four of them come together to allow the virus to replicate the RNA again to make more virus. So they figured, boy, if you can bind to either the Ns5a or the Ns5b, you also could be very successful. Gilead, which owns the Ns5b, they were very fortunate in that sofosbuvir, and the Ns5b is BUVIR. This is actually any resistance that occurred with sofosbuvir was a very unfit strain, and that the virus that came out from the original wild type would only last for a short period of time and fade away in a couple of days. So anyone who was originally treated with the original studies back in 2011, if they got sofosbuvir and they cleared it and people used it by itself, you had success rates for around 75%. If you waited 3 months later and retreated them again, you essentially had a 75% chance of clearing the virus, which is really kind of cool. But we want to do better, so that's why it's combined with other medications. We'll talk about it. Also, there's been success in using Ns5a inhibitors. The Ns5a inhibitors are actually listed here. They all end in ASVIR. These, unfortunately, is very similar to the protease inhibitors, that the resistance that does occur is actually pretty fit, and they will live for a long period of time. So if you get exposed to an Ns5a inhibitor, the next time you may want to avoid that or use something that actually will cover all three. So if you had to pick 2 drugs just to treat hepatitis C, I would tell you use Epclusa, because Epclusa is essentially an Ns5a inhibitor plus an Ns5b inhibitor, or pick Mavyret, which is a protease inhibitor, or a Ns5a inhibitor. Both these work great. The advantage of Mavyret, you can treat people actually for 8 weeks, and you have success rates over 96%. Epclusa, you end up treating people for 12 weeks, success rates over 96%. The only issue with these, or actually how the drug is cleared, the protease inhibitors are all cleared by the liver. So if you have people with advanced liver disease or cirrhosis, you may not want to use Mavyret because the levels can get very high. So in cases of patients with cirrhosis, I tend to use Epclusa. Originally, so how Epclusa is actually cleared by the kidneys. So originally they said you probably shouldn't use it if people had GFRs less than 30, but they did studies, and later on they proved that Epclusa, even though you have higher levels, there's still side effects are so insignificant that you're still pretty good, and you can use Epclusa and use it safely. So it's actually indicated for anyone with any renal problems whatsoever now. So, but these 2 drugs work very well, and success rates over 96%. So really it's cool. Hepatitis C used to be the #1 indication for liver transplant. No longer true. It's now non-alcoholic steatohepatitis. So let's get back to our case now. So now the 60-year-old husband, he actually agreed that he was going to quit because I told him he had cirrhosis. He says, in that case, that's a completely different game. I can quit. And he did. And I treated his hepatitis C. I actually used Epclusa since he had cirrhosis. Since he had cirrhosis and he had some ascites, he's technically considered decompensated. Those individuals, you may need to treat him longer, which I did for 24 weeks, and he's cured. I did do an EGD to screen him for varices since his platelets were less than 150. I did start him on Nadolol to decrease his risk of bleeding. People with medium or large size varices, the risk of bleeding from varices is actually 15% per year. You put them on a beta blocker that decreases it down to 6% per year. The other option is to ban the varices, but there's complications with banding. It's about 5%. So when you look whether you treat someone with band ligation or whether you put them on a beta blocker, I tend to just put them on a beta blocker that's cheaper. If they can't tolerate it, then I'll do the band ligation. But the study is really long-term. They're both about the same. And I also vaccinate against hepatitis A, just because anyone who goes out to eat in a restaurant, the signs that employees must wash their hands is so you don't get hepatitis A. So that's fair. So he's good to go. And here's his labs 1 week later. 1 year later. Sorry about that. So his AST, ALT with hepatitis C treatment has been cleared. His INR is a little bit lower. He did quit alcohol, as he said, and his phosphatidylethanol was negative. I did vaccinate him for Hep A, and he has antibodies to that. His hepatitis C antibody, as we know, that just shows exposure, so that'll be positive for the rest of his life. But his HCV RNA is not detectable, and that should be negative for the rest of his life. Interesting too, in that his alpha-fetoprotein actually normalized, which you see a lot. With regeneration, you tend to have mildly elevated AFPs, but as that regeneration goes away and everything normalizes, the AFP will normalize also. So let's go back to our original patient. So she was getting labs once a week for the first month. She was compliant with her tenofovir. Her appetite was improving. She's still taking care of her mother, and she brought mom into clinic. And I asked her, I said, could mom be the source of hepatitis B? And she said in a loud voice, no, mom is not yellow, and mom has not had sex since dad died 10 years ago. Okay, very good. But I just decided, well, let's just talk to mom. So I'm talking to mom. I said, hey, did you ever get a blood transfusion or anything like that? And she says, you know, when my daughter was born back 55 years ago, I got a blood transfusion. The only time I ever got it, I turned yellow, but this resolved. So I assume I had no other problems. I said, oh, very good. Okay, well, what else is going on? So as I said, she came from Lou Bridges. She was the original Lou Bridges patient. She had psoriatic arthritis. I also mentioned she had diverticulitis. She had a partial colon resection 4 months prior to, complicated by incisional breakdown and required rehospitalization. And then when she went home, she had a wound vac. And it was her daughter who had to take the wound vac and clear it and replace it and take care of her incision. Maybe blood-to-blood exposure there. You know, and the timing 4 months ago helps also. Is there anything else that will push this? Well, she was started on infliximab or Remicade for psoriatic arthritis 8 months earlier. She was also on carvedilol, but that was just for blood pressure control. So you wonder whether the infliximab may have, you know, activated her hepatitis B or reactivated her hepatitis B. And then she had such high levels in the blood that when her daughter was taking care of her wound, whether that was the source of how the daughter got the infection. So let's look further. So she had labs, bilirubin 1.3, AST, ALT 46 and 32, INR 1.15, hepatitis B surface antigens positive, surface antibodies not reactive, E antigens negative, E antibodies positive. So core IgM was negative, core IgG was positive. Her HBV DNA level was greater than 170 million copies per ml. So it sounds like, based on everything, that she's probably had this a lot longer and probably got it when her daughter was born 55 years ago. So she gets an ultrasound. Her ultrasound says she has cirrhosis, splenomegaly, trace ascites. Doppler shows patent hepatic veins, portal veins, hepatic artery, but sluggish flow in the portal vein. So that's probably due to portal hypertension. So where is she in the picture, and how does this all fit into everyone else? So, you know, this is what we associate with people who acquired it at birth. And as we know, when people acquire it at birth, you know, 95% of the people that acquire it at birth actually will maintain a chronic infection for the rest of their lives. Only 5% will they clear it on their own. When you acquire it as an adult, it's the other way around, in that 5% only have a chronic infection, but 95% cleared on their own. So where is she in the picture? Odds are she got it 55 years ago when she gave birth to her daughter. At the time, she probably had very high hepatitis B DNA levels. Okay. I don't know what it is for an adult, but we know if you get it at birth, you know, usually you remain in this immune tolerant phase where you actually get minimal inflammation and minimal fibrosis, and there's really very little damage that goes on right here. But if you get it at birth, it's usually 31 years later when all of a sudden your immune system starts kicking in. Why it kicks in, we have no idea. But on most people, it'll kick in. And then during this time period, your HBV DNA levels will decrease and your ALT levels will increase. There's actually can be significant damage going on during this immune clearance phase. During this time period, your immune system is really essentially killing hepatocytes, and that is causing the inflammation that's going on. For some people, this phase will last a couple months. Some people will last many years. The longer it lasts, the higher the risk you are of developing going on to cirrhosis. Also, during this time period, there is stress on the virus. You know, as I said, you make E antigen, core antigen, surface antigen. On these individuals during this time period, the virus will mutate. When the virus mutates, you'll actually quit making E antigen, and then you'll start developing and you'll have E antibody in your blood. So that's what happens during the immune clearance phase. Whenever people get over this, it resolves. You tend to be an inactive carrier state, where again, now you're back to low levels of HBV DNA, low levels of ALT, and really very little damage goes on during the inactive carrier state. But for some people, this can be turned into a reactivation phase. And I think in our particular patient, I think when she started her Remicade or infliximab, I think that's what caused her reactivation, her HBV DNA levels go up, her ALT levels go up, and then her incision starts weeping out hepatitis B virus. And that's what caused the daughter to get infected. So as you see here, this is where I think she is. So she has a chronic disease, she has cirrhosis. So what do we do with her? So I put her also on tenofovir. And I told her she doesn't need an EGD since she's on carvedilol, so that's decreasing the risk of her bleeding from varices. And essentially over time, her incision is healed and she's moved back to her own house. So what happened to her labs? So now we look a year later. Her bilirubin is normalized. Her alkaline phosphatase is normalized. Her AST, ALT have normalized. Her INR has come down. She is still hepatitis B surface antigen positive, right? This is going to happen. They're going to remain positive. Most people for the rest of their lives, there's probably like 1% chance that people will actually lose surface antigen, but that's pretty rare. And her HBV DNA level went from greater than, I'm sorry, this is 170 million, sorry, down to 5 million. I'm sorry, 5,000. Sorry about that. So what do I expect when someone takes hepatitis B treatment with the new agents, either tenofovir or entecavir? I really expect you to lose about a log every month. So she's probably pretty close to losing everything. And I know the next time I checked her, which was 3 months later, her virus was gone. So let's go back to our original patient. So she got followed up for 1 month later. She's taking her tenofovir. Her appetite's back to normal. Okay. This is her labs. Her bilirubin went from 28 down to 6.5. AST, ALT are improving. Iron studies are coming back down. INR is back to normal. She was surface antigen still positive. E antigen still positive. And essentially DNA went from 800,000 down to 600 essentially within a month. Okay, which is, it was probably going down anyway. So you can't say, well, but tenofovir really did a great job. It was probably just going to happen anyway, but hopefully we sped up the process. So as I said, you know, our 55-year-old female, she is actually was here, she's recovering, and she should, but she's still in the symptomatic phase because it's only a month later. But with time, she will recover from this. Okay, and we see 6 months later now that everything essentially is normalized. She has lost surface antigen, she has lost E antigen, and she has antibodies to that. At this point in time, I can stop her tenofovir, which is what I did. Okay, and so she's in the recovery phase, as we see right here. So here's your family follow-up. So essentially the 55-year-old female that started all this, she's offered tenofovir. Ultrasound still says she has a nodular liver. And we always questioned that when we saw it originally, but I have followed up actually with ultrasound elastography, which I really love. They put a probe on your liver. They pick 10 different sites. They, instead of doing continuous waves, they will send a bolus wave. If your liver is stiff, it's going to hit it and come back quickly. If it's soft like a pillow, it'll be cushioned and come back slower. They can measure that difference in time, and they can give you the stiffness of your liver. The higher that number, the stiffer the liver is. And essentially, if you have a result that's 7.5 or less, you really have no cirrhosis. If it's greater than 15, you do have cirrhosis. In between, there's an overlap range. But her ultrasound actually, since it still kept reading that she had a nodular surface, I actually did an MR elastography, which is very similar to the ultrasound elastography, but they put a vibrator actually on your abdomen, and that sends sound waves that way. They repeat the MRI, and they can measure stiffness too, and her liver was completely normal from that. So she should be good to go, right? As for her mom is still taking her tenofovir, living independently and getting ultrasounds every 6 months because, as I said, she's at risk of developing hepatocellular carcinoma. I tend to favor CT scans once a year because I think it gives us more information. Although here, and you have to know where you're at, I think they do. I know they do a great job here reading ultrasounds. but you can still miss, unfortunately, some infiltrative HCCs. So if you're not getting a CT scan once a year, you need to at least get ultrasounds every 6 months. As for our patient's original patient's husband, he is off alcohol. He's getting ultrasounds also every 6 months. And the patient and her husband are still married. Hopefully they're happily married. So with that, I guess I will open it up to questions and we can go from there. I'll stop sharing and see what we have. Yell it out, whatever you have. I have no chat question. Don't tell me you understood everything that I said. Ashley, it's a smart crowd.
I can speak for the group and say that was very informative and educational. I know everybody learned something.
Very good. Okay. Any questions, last call, or I'll let you guys go. Okay. Well, thank you guys. Appreciate it. Okay.
Thank you so much for your time, Brendan.
You got it, guys. Have a great day. Okay. Bye-bye.
Bye.